but we are inviting Dr. Jayesh Prajapati. He has a flight to catch, so he'll be taking a talk on newer balloons and DEBs. Dr. Jayesh is a senior professor, interventional cardiologist of acclaim from UN Mehta in Ahmedabad, a good friend, and I'm eager to hear him about.
Uh, Thank you, Dr. Rishi Shetty, for my kind introduction, and good afternoon to chairperson and all dear friends. And thanks to Lupin for organizing this symposium, and of course the TCT India, Srinivas Kumar and Rishi Shetty for inviting me. So today I'm going to talk in I think 15-20 minutes time regarding the newer balloons and drug-eluting balloon. As per, I'll focus on that. So we know the conventional coronary balloons that are the main regular balloon, what we are using it, the compliant balloon and semi-compliant. So we use semi-compliant balloon for the pre-dilatation, most of the cases, non-compliant balloon for the post-dilatation, means post-stenting optimization. And of course, then some of the special modified balloon that what we are using are the scoring balloon like angiosculpt and that kind of balloon, while the cutting balloon that has been now to modify the calcium, that is what we are using it. Another high pressure balloon, that is OP and NC, they can go up to 30-50 atmosphere pressure, and they can, particularly for the calcific lesions, these are one of the useful balloon. They are a non-compliant balloon, but it doesn't expand much. And of course, these are the good balloon for sometime once you have implanted the stent, we are not able to dilate with root regular NC balloon, then these are the ones balloon, these are useful. And of course, we know the IVL also, which has nowadays is a very good tool where we are not able to crack the calcium after even after rotablation or something like the focal calcium and all. So IABP and I don't want to touch upon. So today I'm basically going to discuss mainly on the drug-eluting balloon. So this is already I have discussed. So we know that after we want invention of these stents, nowadays DES is to be considered the gold standard, newer generations. But we are searching for, nowadays we are facing the problem with the DES also. Because DES carries a late catch-up. Every year, 2% to 3% of the patient then late catch-up means 3 years, 5 years. Down the time, they come with a new atherosclerosis. And DES failure nowadays is a non-thing. So how many layer we implant? So we are trying nowadays, world is trying to make a metal-free coronary or metal-free vessel. So we have tried with the absorb and all biodegradable stents and all, but somehow, unfortunately, there are some problems, late thrombosis and all these things. So then the nowadays, since last, I think 5 to 7 years, mainly we are focusing on drug-eluting balloon. And sometime also we are thinking that indication are expanding. So this is basically has been introduced, particularly leaving nothing behind. So that is one of the important, how many metal layer we can implant. Sometimes one restenosis, suppose bare metal restenosis there, we have implanted DES. And then what next? 2 layer, after 2 layer, it is not better not to put any more layer into the coronary. So DEB concept was born in 2000. And which are the 2 drugs? We are using mainly 2 drugs, Limus drug and Taxol drug. So paclitaxel nowadays in coronary stent is out. But of course, the drug-eluting balloon, when we see the literature, the paclitaxel is people say that paclitaxel is a drug which required for the drug-eluting balloon because this is a lipophilic drug and this drug fits for the drug-eluting balloon. So data says that the paclitaxel is a most classic, but when you use a sirolimus as a drug-eluting balloon, then we have to think twice because it's not a class effect, because sirolimus drug is a water soluble, not a lipid soluble, so doesn't transfer. Why when we coat any balloon with a drugs, that drugs should transfer to the vessel wall. That is important. So transfer should be fast. When inflate a balloon, we have got a limit time. We can keep it to 45 seconds or 1 minute or something like that. So transfer time should be less, and the drug should be maintained into that vessel. It should not wash out into the circulation. So drugs should stay into that cell. So that is important thing, and we should find a drug. So there are so many animal study has been done, and then the drug-eluting balloon were evaluated. And of course, the safety, we know the sirolimus is a relatively safe drug compared to Taxol. That's why most of the stents are the limus coated stents. So this is important technology. So DEB, one thing when we do a DEB, drug-eluting balloon, and how to implant that I'll discuss later. But important advantage, we are leaving nothing behind. Another thing is thrombosis rate is low. Once we put a drug-eluting balloon, we have to keep in contact. Each company gives the idea 45 seconds to 1 minute. And once you open a drug-eluting balloon, once it should be in the circulation, you have to be sure that that balloon should go to that site. So lesion preparation is a must. So transfer time within 2 minutes. Some say that 2 minutes the time you should finish you should reach to that target area. And 2 mm at the both the edges, it should be covered. So you have to, and 1:1 ratio is a must. So that's something. And once you are open, suppose you have not crossed the lesion, and then you are coming back, never put that balloon again because your drug has lost. So that is one of the important things while using a drug-eluting balloon. Previously, older balloons where got a profile was bad, but the newer balloons, they have got a good crossability profile. So these are some of the commercially available drug-eluting balloon. Among the paclitaxel, some are nowadays, I think, FDA approved is the Boston Scientific and Medtronic. These are the available balloon. And of course, the oldest balloon was the sequent, please, B. Brown. B. Brown was the first company that has launched the paclitaxel, and most of the data with the sequent, please, balloon. And nowadays, sirolimus eluting balloons are available. Among them, the good study available is the sequent, please, SCB balloon, and that is a crystalline sirolimus. And this balloon has shown that drug remain inside the coronary up to 30 days. So that is one of the important thing. And some of the one or two Indian company, that is Magic Touch. But data, we have to see more data needed in that balloon because the last study has failed in non-inferiority compared with the paclitaxel balloon. So that we have to keep in mind with the sirolimus. So sirolimus eluting balloon, it is not a class effect. We require more data. So which are the various indication where we should use a DEB? Because DEB nowadays indications are expanding. One important thing is that whenever you implant a DEB, always we have to accept angiographic result should be acceptable. So at least we have to dial it to 1:1 ratio. So preparation of the bed should be very well. Suppose it's a calcific lesion, you have to burr it, rotabur, then do a balloon dye with a semi-compliant, non-compliant. Prepare the lesion very well. Some say FFR of 0.9 is up, but data say up to 0.8 FFR, less than 0.8 FFR is there. Then more than 0.8 FFR, you can implant a drug-eluting balloon. So we have to prepare the lesion very well. In case of ISR, it is better to go do a imaging and then to decide whether to go for DEB or something like that. And if there is suboptimal result, we have to see for the TIMI flow and we have to see the dissection. Up to 1, 2, you can, up to, some say up to 3, but 1 to 2 grade dissection, you can put a DEB. And suppose flow is compromised and dissection is major, you have to implant a drug-eluting stent or whatsoever stent you want. So one indication where this is a class 1 recommendation level of evidence A is an instant restenosis. There are data available with BMS instant restenosis. There were data initially with the drug-eluting balloon and plain balloon. Of course, the drug-eluting balloon is better compared to the plain balloon angioplasty. And with bare metal restenosis, I always and most of the people prefer that DES is the first choice. So first time. But if the second layer is then it is always better to go with a drug-eluting balloon. And some people even advocate that even the first time drug-eluting stent restenosis, why to implant a second stent? We can give a try of a drug-eluting balloon, so we can in the future we can get an option of second drug-eluting stent implantation the same lesion. So class 1 recommendation is ISR. These are some of the data, some of the studies, and some of the data and meta-analysis. I don't want to go into detail of that, BMS versus DES, but all this restenosis, it is nowadays better to do imaging because the BMS and DES restenosis is a different thing. And these are some of the meta-analysis they carried out and conclusion what I have told. Another expanding indication is the small vessel disease. Small vessel disease nowadays, we are doing so many multi-vessel angioplasties. So small vessel disease, vessel less than 2.75, some say up to 3 remaining a challenging. But of course, world is divided. We have seen that even the DES technology, even up to 2.5, 2.75 or 3 DES are of course a good choice, but people are moving in their small vessel. Even the small vessel data are available with a drug-eluting balloon, particularly paclitaxel eluting balloon. And it has shown that 3-year long-term data is available. And of course, this is also one of the good alternative in a small vessel, particularly side branches and all. So small vessel, these are the studies, particularly basket small 2 trial. And this has shown that these are good data with this one. Another now one thing is newer thing is the larger vessels. People now started using the DEB in larger vessel. We know that in a larger vessel, 3.5, 4 mm, 3.25 mm, people have tried the DEB and they have shown that large vessel, they have shown that even some of the dissection we can leave it and we leave no metal. So there are the small data available with a larger vessel also. Suppose long lesion is there, then larger vessel people have tried using this drug-eluting balloon also. Another most important thing is a bifurcation. We know that the European Bifurcation Club recommendation is always we know the provisional stenting. So what to do for side branch? So they say that main vessel drug-eluting stent, side branch, you can finish with a kissing balloon, with a drug-eluting balloon, or prepare the side branch very well and finish with a drug-eluting balloon. So this is the one thing where the drug-eluting balloon has got a good role. Second thing is that suppose you have got a bifurcation, you have implanted DES and DES restenosis, then what to do? Then some say that rather than implanting a second DES into same site, you can compromise the side branch. That is always a worry because two metal layers are there. So they said in care, why not two DEB, main vessel and side branch? So this is also one of the concept which is going on. So side branch DEB versus both the DEB, that also one of the things to be considered, particularly for the bifurcation lesion. So that thing is also going on. Another thing is particularly country like India, where the diabetic population is more, and diabetic patient, they have got a small vessel, diffuse disease, multiple stenosis, and the diameter mismatch is there. Some say that to put a drug-eluting stent, longer stent, there will be a drug delivery will be not the same. Rather than you put a drug-eluting balloon, then probably the lower the restenosis rate, and then later on you can give a chance for a DES. So for the diabetic patient, the small vessel, you prepare the lesion very well, and in that small vessel, long lesion, you can try a drug-eluting balloon. This is one of the indication, expanding indication for the drug-eluting balloon. Another important thing is high bleeding risk group of patients. DEB, they recommended that DAPT to be given up to 4 weeks is enough in selected cases. After then, suppose patient have got atrial fibrillation, they are requiring NOAC or something like that. So you can give single antiplatelet plus NOAC or something like that. Or the patient suppose requiring a surgery in near future. Then if you want to give a shorter term DAPT, then this is one of the good thing. Even they have given a single antiplatelet and they did a DEB, the thrombosis rate is they say 0.2 to 5%. So lower thrombosis risk with DEB. So DEB carries a lower thrombosis risk. So patient with a high bleeding risk requiring urgent surgery. So that group of patient data is there. Then this group of patient, probably the DEB is one of the good choice. Another people have now started using drug-eluting balloon, even ACS situation. Of course, this area is very tricky, little controversial, because the ACS carries a thrombus, and the vessel diameter, we cannot exactly judge what is the vessel diameter. Another, thrombus is a barrier, and third thing is a flow. So even though they have tried in the non-ST elevation MI, drug-eluting balloon, STEMI, they have cleared the thrombus, and they leave the patient once the flow has been established and defer DEB. Or if the patient has got a no flow, something like that, then optional stent. So even the ACS situation, people are trying. So this is one of the expanding indication, and some more data is needed, but small data around 100, 200 patients for the efficacy and safety. People have tried and they are not gone situation. So thrombotic ACS situation also, the probably DEB will be the option in the future. So these are some of the small studies which are available in ACS situation, non-ST elevation MI, ST elevation MI, deferred stenting, or deferred DEB or DES as an option. So we know that these are the slides showing the advantage and disadvantage of DEB. As I was told, one important thing is that lower DAPT, less implant. So this is one of the biggest advantage. And disadvantage is that sometimes a flow limiting dissection, there you have to implant a stent. So DEB should be tried first in most of the situation. So when we see that, to finalize my talk, so paclitaxel eluting balloons are nowadays one of the most investigated balloon. And of course, when you use a DEB, we have to implant it properly. So lesion preparation is a must while you use a DEB, and we have to take care that balloon should be delivered. Sometime what happened? We are going to use a 40 mm balloon. Then sometime it is better to check with another long balloon whether we can pass that balloon to that lesion site. Otherwise, that drug-eluting balloon will be wasted. So that we think we should keep in mind. And indication, class 1 indication is the ISR, particularly DES ISR. Another indication is a bifurcation, followed by small vessel, and expanding indications are the diabetic patients, and of course, long vessel and ACS situation. I can say it is early to say whether the DEB should be used or not. Thank you so much.